So I did want to point out to you how important this material is. You can see I highlighted for you the areas that we will be covering in the next 4 hours. So this is the content areas that represent 3% or greater, and if you put those together, the general peds content comes to close to 30% of the exam. So this is material that represents a big portion of the exam. This outline here shows you the tour that we're going to take for the next 4 hours, and I'm going to try to pace it for you at a reasonably comfortable pace, but we'll also check periodically just so you can be reminded where we are at in the process. So first we need to talk about some normal growth, normal weight gain pearls. Invariably there's a test question on this. The kinds of things I would suggest you look for in particular are a question that seems to be asking something, directing you in a particular place. Always just check the weight. Make sure that the growth parameters are normal. That's something that you could easily overlook, and it's something that's likely to be tested. So birth weight's regained within 2 weeks. Maximum weight loss in the first 2 weeks is 10%. That's one of the board's favorite questions, is having a baby come in for a checkup after being discharged from the nursery who's lost more than 10% of their birth weight. And that should be a flag for you. Weight doubles in 4 months, triples at 12 months, quadruples at 24 months. So as I said, just always be sure you check the growth parameters in the question. Height gain in the first year, a 50% gain, doubles at 4 years and triples at 13 years. Again, be sure to check those parameters. For preemies, we plot on the usual curve, but we allow catch-up. Generally speaking, we allow for 2 years of catch-up growth, but a lot of that growth hopefully is going to happen in the first year. We're going to talk a little bit more about prematurity and its impact on a variety of different parameters. But you should correct for gestational age until about the chronologic age of 2. For weight, check the weight of the child at every visit, regardless of the visit. Another thing they might hang you up on is an urgent care visit. Make sure you check the weight. We have transitioned to a body mass index for those over 2, and we're going to plot that on the usual curves. Lengths, all patients should have a length or a height measurement. Length is in the recumbent position up until age 2 or 3, and then after that we measure a standing height and plot that. For head circumference, few are aware that the standard actually calls for you to measure the head circumference 3 times with a non-flexible tape across the frontal occipital dimension, and then to take the greatest of those 3 measurements. So here's a question to wake you up after that Mexican lunch. A 6-month-old male is brought to your office for a well child checkup. The family has just moved into town. You plot his height and weight and note both to be at the 5th percentile for age. After collecting a complete history, which is unremarkable, and completing a physical exam with no abnormalities, your first step would be to A, obtain old growth charts, B, order a basic metabolic profile with a venous pH, C, place the baby on a high-calorie diet, D, schedule a nutrition consult, or E, ask the office's social worker to interview the family. So grab your button box, and here we go. All right, so that was a good warm-up question for you. Glad to see that we're all on the same page. So the point here is that there's really several points to make. One is that we're moving away from intervention generally. So in a lot of situations that we're going to be talking about today, we're going to actually talk about an approach that's evolved a little bit over the last couple decades, and that is to use your brain more and use the lab less. It's good. Nobody wanted to order any testing. It's also important to point out that no single growth measurement has real meaning. It has to be compared to a trend or what's happened in the past. So the most important thing in this case would be to first take a look at old charts to see where this child has been, where their birth parameters were at, and to check to see if there was any change. What are the trends, which way, changes over time. We particularly talk about percentile groups, but you know those are relatively arbitrary. It's also important to make comparisons across the parameters, so comparing height to weight to head circumference. How do they compare to one another? One of the things we're going to talk about a little bit later is about how you can actually make a diagnosis or categorize your diagnoses by the way the growth parameters are changing. So I want to spend just a minute to remind you of the normal bell curve. Everyone's seen this, but it's helpful to notice that we talk about this distribution that gives us this nice shape, but we always need to think about what's in the tails. So 5% of the population, by definition, falls 2 standard deviations outside of the mean. So that's how we define any normal parameter. So just remember that as you're going through this. So if you take IQ as an example, you can see the 2.5% tails on each end. That is a part of the definition of what creates the normal range. Growth charts, you guys all use these all the time. They're very familiar to you. You recognize that they're in a variety of different formats and that you can use different growth charts depending upon your situation. So you want to look particularly, obviously, at the age of the child, the gender of the child, and whether you're looking at length for age or weight for age, depending upon what you're measuring and what your concerns are. But these are charts you've all seen. They're available now, of course, on the web. But we plot length for age and weight for age. And basically, in most of the questions that you're going to face that have growth issues, you want to be familiar with how to compare those parameters and how they would be charted. So here's the boys' head circumference for age and weight for length, and girls' weight for stature. And then boys, the body mass index. Why do we use the body mass index? Well, it's a better way to actually measure percent fat without actually directly measuring it. There are special growth curves available, so many of you are working with international adoptees. Some of you might be working with children with handicaps or other problems that are going to naturally affect their growth. So you can often get many of these on the web or from other sources, but particularly think about Down syndrome, Turner syndrome, and certain ethnic backgrounds when you're dealing with international adoptees. So here's an example for you. This is the weight for age for boys with Down syndrome between the ages of 2 and 18. And it's a different growth chart. So it's important for you to use that if you're dealing with a patient who has Down syndrome. The body mass index, as I mentioned, is a pretty reliable indicator of body fat content, and it means you don't have to go through the rigmarole of actually measuring body fat directly. It's a very effective way to assess for some types of health problems. And we talk about categories as underweight, healthy weight, overweight, and obese, and we're going to go through more of that as well. But the norms are specific to both age and gender. So here's the actual calculation. I don't think you need to memorize this, but it is a mathematical calculation. And here's an example, and you can see that if you take a 10-year-old boy, first it's showing you the 95th percentile here. He's categorized as obese in that case. Another boy, also 10 years old with a BMI of 21, would be in this category here, falling in this band. We talk about that as being overweight. The normal weight is the green band, and underneath is the underweight band. So we've been asked to adopt these types of phrases in terms of describing BMI for patients. Here's another example where the same BMI is going to categorize the patient in a different category. 10-year-old boy with a BMI of 23 here would be obese, whereas a 15-year-old boy with the same BMI here is of normal weight. So again, here is the definition for you. Underweight less than the 5th percentile, healthy weight between 5 and 85, overweight 85 to 95, and obese greater than 95. So what determines growth? And as you know, there are a variety of different things, and we're going to look at some of the factors, but We talk about the environment. We talk about hormones and genes as well. Adult height of the two parents seems to be relatively predictive of a child's height and also relatively predictive of when a child's going to go through growth spurts. We're going to talk for a while now about anticipatory guidance and health supervision. This is a huge topic in pediatrics, as you know. And we're going to start out with another question for you. When should the pediatrician provide health supervision or counseling? A, only once in a while because this role is now filled regularly by nurses in offices that operate efficiently. B, annually using a checklist to track the advice given. C, with health maintenance visits, reserving other visits to focus on the management of medical problems. Or D, with every visit regardless of the reason for the visit. So grab your button box and make a choice. All right, so you look at a question like this, and again, you guys did well. It's a good warm-up for you. But all of those answers seem somewhat reasonable, and you might employ some combination of those techniques. But you all narrowed in and figured out what the board's looking for. They're looking for you to provide some advice to the patient and or the parents at every single visit, regardless of the reason for the visit. And so that's the take-home message. Every single visit should involve some counseling and or the providing of health supervision. So how do you do it? I mean, more is not necessarily better. We're all crunched for time now, generating those RVUs and trying to keep up with the changing world and the economics of medicine. So you can't just keep droning on about supervising this, that, and the other thing. You need to focus your counseling, and how are you going to do that? So the boards really want you to do it in two ways. One is by the age of the patient, and two is by the reason that brings them in to see you. So you need to prioritize based on the context of the visit. And so it's much better to actually relate the advice that you're giving directly to the reason for the visit. So when you look at it by age, your counseling is going to change based on what the parents are concerned about and based on the issues that they're likely to face with their child as he or she grows. But the ones that are most likely to be presented to you on the exam are among the lists that I gave you. So feeding, injury prevention, huge, asterisk, red light, whatever you want to do in your book, say you need to be aware of injury prevention. That's a huge topic right now. Developmental milestones has always been a topic. It never seems to go away. Behavioral issues, daily care, and then always anticipate what are the next steps going to be for this patient? What are the problems going to be? So let's take an example. 7-year-old presents with wrist pain after a fall from his skateboard. So what's your first question? Were you wearing a helmet, right? So any wheeled activity warrants a helmet. So health supervision is going to be making sure that the child's wearing protective gear, helmet, in the correct position, right, because the kids are all wearing the helmets wrong. So just like you put the seat belts on right and you put the safety seat in the car right, we need to talk about how the helmet needs to be pushed forward so the forehead is protected. Wrist guards, knee pads, but this is a way to tailor your advice to the reason that the child is seeing you. 2-month-old, what would you do? Long list of things. You can read it there, but these are the things that the boards are really going to focus on. So again, you can highlight some of the things that tend to be higher value items these days. So we talk specifically about immunizations, management of the common cold. Those seem to be more hot topics, but all of these kinds of things are fair game, and this is a fair kind of list that you'd be dealing with at a 2-month checkup. So for the test, really think about those items that seem to be focused on more these days with the exam. So wheeled activities and skiing, wearing helmets. Dental exams, we're being asked to get kids dental homes now, and we really need to get kids in for an appointment before the age of 3. And then drugs and sexual activity is a huge topic for the boards, and they want you to start your conversations with your patients by age 10 on these topics. Restraints when traveling by car. It's important to recognize that the majority of children traveling in cars are not properly restrained. And this is an evolving topic, as you know. The guidelines about how to install seats and who faces forwards and who faces the rear is important for you to recognize as you go into the exam. Injuries, another huge topic for the boards. And why is that? Because accidents are the leading cause of death all the way through adolescence. So this is considered a preventable disease. Injuries are the most common cause of morbidity as well. And for car safety in particular, 75% of deaths from injury are due to motor vehicle accidents. So restraints need to be specific to the age and weight of the child, which I mentioned. So other important issues that may be the focus of some of the questions, the use of smoke detectors, making sure hot water heater temperatures are 120 degrees or below, talking about animal bites, and that's not just strange animals, that's friendly animals as well. So pets in the home, toxic substance storage, choking hazards. We talked a little bit about sports safety with helmets and such. Firearm safety, how do you store firearms? Are there firearms in the house? Is the ammunition kept separately from the gun itself? Is it locked so it's away from potentially being discovered by any child in the home? Alcohol and drug use, again, highlight that one. It's huge. There's a guarantee that you're going to get questions about that, in particular counseling patients at an earlier age about alcohol and drug use. Suicide prevention, homicide prevention, and drowning prevention. So is there any access to a pool in the home? Do the kids go anywhere where there might be a pool? What about teeth? Need to talk a little bit about teeth. Development begins usually at around 6 months of age, 20 primary teeth by age 2. Some symptoms of teething that you're all very familiar with. It unfortunately mimics some illnesses, so you need to be aware of that as well. You don't always want to just chalk it up to teething. Make sure there isn't something else going on that you might miss. So another question for you. One evening, the father of an 18-month-old boy calls you reporting that the boy just fell while playing in the house. He hit his mouth on the edge of a coffee table and knocked out one of his primary front teeth. You establish that no head injury has occurred. The bleeding's been controlled, and there's no damage to the jaw or soft tissues of the face. What do you tell the father to do regarding the dislodged tooth? A, nothing. The tooth can be saved as a keepsake. B, place the tooth in cold milk and see a dentist in the morning. C, wash the tooth in cold water and replace it in its original position in the child's mouth. Or D, go immediately to the nearest emergency department for the tooth to be wired back into place. So grab your box and choose one of those. So we got a little bit of a split decision here. Actually, you know, the way the question's written, it seems like A is the wrong answer, right? Because you just instinctively think, well, you can't just do nothing. But actually, that is the correct answer. There is no need to replace a primary tooth as long as the secondary tooth has not been affected. So even though the parent's probably not going to be entirely happy with your answer in this case, there isn't a whole lot to be done to replace that primary tooth. So again, the other answers may lead to, may have some pieces of them that are right. Placing the tooth in cold milk or washing the tooth and replacing it in its original position may or may not survive. You know, probably not. So the bottom line is a primary tooth without disruption to the tooth behind it is not necessarily anything other than a cosmetic problem. Gives you a sense with this chart about when teeth erupt. So there are some diseases that are associated with delayed tooth eruption that you may be asked to think about. If a patient comes to you and has delayed tooth eruption, these are the kinds of things to think about. Impacted teeth sometimes need a surgical intervention. It means that they're not able to erupt spontaneously. A child who's had cancer or some other reason to have cytotoxic therapy or radiotherapy may have delayed tooth eruption. You need to think about whether there are other craniofacial abnormalities associated with the delay in the teeth eruption. Congenital hypopituitarism and congenital hypothyroidism, two things to think about. Not common, but it's not something you'd want to miss. So worth testing for in a child who has delayed tooth eruption. And then some genetic syndromes, especially Down syndrome, are associated with a delay. The bottom line, if there's no teeth within 6 months of the target eruption, you should refer the patient to a dentist for a complete evaluation. Routine dental care, as I mentioned, is another topic that seems to be coming up a lot. The thrust of what is being asked is making sure that the kids get seen early. So establishing a dental home for them and making sure that they're comfortable in the dental situation and they can be seen by a dentist who can appropriately care for a pediatric patient. I listed for you some of the high risks for dental caries, but none that should be surprising to you. Probably the biggest one is the social situation. But there are some other biological problems that can lead to increased risk for dental caries. Fluoride varnish, some of you may be using this. How many people are using fluoride varnish in the office? So actually not that many. I'm sort of surprised. So it is something that is I think, becoming more common. There's evidence now that having fluoride varnish applied on a regular basis is actually a pretty effective way to prevent dental caries. It's not considered a substitute for fluorinated water, for toothpaste, or any other necessary sealants. It is something that can be done relatively easily in the office, usually applied 4 times a year. Start after the first primary tooth erupts, and then consider a part of the well patient visits. All right, we're going to shift gears a little bit and move into common screening tests. So this is a document that you should absolutely be familiar with. It's fairly easy to read and work with. It represents what I would say are consensus guidelines from the American Academy of Pediatrics. So it's downloadable on the web. So if you just go to Bright Futures, you'll find it. And this is kind of a scary little chart here. But what I would suggest to you is that you download a copy of this and you read the fine print. Normally we all ignore the fine print. I mean, when was the last time when you were asked to check the terms of agreement and you actually read what those terms were? Probably none of you ever do. I know I don't. But this is fine print that's worth reading and understanding. And if you can go through this chart and completely understand every single one of those footnotes, what's at the bottom in the fine print is all the footnotes for all the various testing. And it all makes sense, and I think you'll find it to be logical, but you need to understand it and be pretty familiar with it. Every circle on the chart represents a required screening test. Every star represents something that should be done based on risk or a target screening population. Something that's really good for you to do is to download this and take a look at it before the exam and really get to know the recommendations. These are the things that were in the left column here. So everything that's here, I just reprinted it for you. So one of the things that I want to remind you is the difference between screening tests and diagnostic tests. This is actually something that's really, really important to understand as you're approaching the questions that you're going to face. So what is a screening test? Screening test is only used on a patient for whom you don't have any specific suspicions. It's not targeted. For whom the patient does not have any particular risks that you know of that are going to lead to a different approach, and who doesn't already have a disease. So it's meant to be applied to a large number of people, mass application, of all of whom are asymptomatic. So as soon as there's a symptom that could be related to why you're screening the patient, it kicks you out of the screening mode. You're no longer screening. Okay, so that's important to realize. You've moved into the diagnostic testing realm. So this is when you have a reason to be suspicious that a disease exists, and you use the lab and other techniques to make a diagnosis. So very, very different than screening. So let's talk a little bit about vision, what's normal, what's not. Red reflex you should be checking routinely, starting with the very first visit in the office. So you just simply use the ophthalmoscope to look for the reflection of the blood in the back of the eye. Creates a nice red appearance, easy to screen, real quick. You can also check by 4 months of age that there's object tracking. Real easy thing to do is just pull a set of keys out of your pocket and jangle them and move them across, see if the patient can follow them. A conjugate gaze, which this cat obviously doesn't have at the moment. There's a pretty easy test called the unilateral cover-uncover test, which you can use to check for whether the patient's gaze is conjugate or not. We're asked to do this in toddlers and preschoolers, and it is to check for the alignment of the visual axis. And so there's a real easy way to illustrate this, and it's fairly memorable. So you realize that your eyes, your two eyes, send to your brain different images, right? And so your brain has to integrate those images. And many of us have actually a dominant eye. So there's a pretty easy way to sort this out. If you put your fingers like this, you go ahead and try this, it's kind of fun. So pick a light up on the ceiling and put it in the middle with both your eyes open. Okay, and when you've done that, then move your eyes left and right, alternating opening and closing left and right eyes, and you see the light moves inside that triangle, right? Now, for some of you, you might find that it doesn't move that much. You've got a more dominant eye. For others of you, it might move quite a bit, and then your eyes are fairly equal. But the job of the brain, in that simple illustration, the job of the brain is to integrate those two images. So what happens in a patient who has a markedly disconjugate gaze is the brain doesn't have the capacity then to integrate those two images. And so what does it do? It ignores one of the images. And so what ends up happening, especially as vision is developing, you have the potential to lose the vision in that eye. So the cover-uncover test is a pretty simple way of checking for whether or not the child needs to make any adjustment in the weaker eye as you cover the stronger eye, if there is a difference. And so if you cover the stronger eye, then the only image the brain is getting is the weaker eye. It'll move to the position to see that image. But as soon as you uncover the strong eye, the weaker eye will move away as the stronger eye picks up the focus on that image. Snellen chart, you've all seen this. You probably have one in your office. You post it on the back of a door. You mark out 20 feet. You put a mark on the floor, and that's how you screen vision. There are shortcuts, the handheld cards that could be done at a shorter distance. But basically, when we talk about 20/20 vision, what we're talking about is that the patient sees at 20 feet what most people see at 20 feet. Right? So this is a way of measuring, if you're way up here at 2200, you're seeing at 20 feet what most people can see at 200 feet. So 20/20 is this normal line down here, and that's how we screen. The screening method we apply for patients who can use a chart like this. There are charts that are made for younger kids. They have animals and other objects on them, and you can use that if the child is at the pre-reading level. The red-green bars are there just to check for color blindness. So in newborns, you want to ensure the ocular structures are intact. There are no abnormalities. You want to look specifically for cataracts or corneal opacities or any ptosis. That's where the lid is lagging a bit and may obstruct vision. You want to check this at birth and at all well child checks. And the earliest possible age you want to check with special charts, usually around the age of 3, to check for visual acuity. So who do you send to the eye doctor? Anyone who's very premature, positive family history of any of the things I've listed for you, any developmental delay. We're going to really hammer home the fact that whenever there's developmental delay, one of the first things you need to do is check vision and screening. So that should be, hopefully by the end of this talk, just an automatic thing, that when you're faced with a developmental delay, the first thing you do is screen vision and hearing. Any neurologic problems or systemic diseases that are going to be associated with eye abnormality warrant a referral with the ophthalmologist. All right, in the last 10 years, hearing screening has been a big topic of discussion. And why is that? Well, what makes an effective screening test? One of the things that has to be true is the test has to be able to apply to a large population, has to be a test that most patients can reasonably tolerate, right? So it can't be a test like the problem with cancer screening with colonoscopy is, right, nobody wants a colonoscopy. So that's probably not the best screening tool to apply to a mass population. The other factor about a successful screening test is early intervention needs to make a difference. So we used to get chest x-rays on smokers. I remember when I was a med student and I was in the internal medicine clinic, we'd always check an annual chest x-ray on every smoker. The reason is we thought we could catch cancer early. Turned out we couldn't. We couldn't catch it any earlier than if we waited until the patient had another symptom. So we stopped doing that. But hearing screening is a situation where we know early intervention makes a huge difference. And so we're all being asked to screen all patients for their hearing. So deafness is a relatively common problem. And so now the AAP recommends universal hearing. So 100% of patients should be screened by age 3 months, but there's no specific mechanism that's recommended. For most of you working out there, you probably have a protocol in your nursery when babies are born for them to be tested. When should you be more aggressive? Parental concerns about either hearing or speech. And a lot of questions that you're going to be faced with on the exam are going to start out with a parental concern. So I would suggest to you that in board questions, those concerns are always valid. Okay, so in real practice, we all know that we have to sift through a lot of not so valid concerns from parents to find the valid ones. But I'll tell you on the board questions, I'd take every parental concern seriously. History of bacterial meningitis, neonatal CMV, mumps or measles is also another reason because, to be more aggressive because all those can affect hearing. Syndromes, ototoxic medication, gentamicin is one that a newborn might have been exposed to, or a known neurodegenerative disorder that's associated with hearing loss. Blood pressure screening. Should be doing it every year after 3 years of age, and before 3 years of age if there are risk factors present for high blood pressure, either medical conditions or some known situation that might put the patient at higher risk for having high blood pressure. Hypertension. Remember that you can't label a patient as hypertensive on a single measurement. It's kind of like growth parameters. We don't want to make a statement about their growth without comparing situation across time. So you need at least 3 measurements. They should be done serially in different situations or different days. Certainly if you're faced with a blood pressure that's really high, you want to take that very seriously and not wait for 2 or 3 measurements. But generally the standard is before diagnosing hypertension, you want serial readings. All right, we have another case for you to consider. In this case, the parents of a 4-year-old, previously well boy, report that he, quote, walks funny. The child appears well and has no complaints, although the parents report that he occasionally complains of leg aches. After doing a complete history and physical, in which you find no abnormalities, you're inclined to employ watchful waiting. That's okay in most cases, by the way. At the parent's insistence, you order a bilateral knee x-rays. The results are shown in the following slide, and the question is, which of the following blood tests should be ordered for this child? So take a minute to look at that x-ray. And then answer the question, which of the following blood tests should be ordered for this child? An ANA, B, a rheumatoid factor, C, a complete blood count, D, an ESR, or E, a lead level. Excellent. So you all saw what we are looking for in the x-ray, which are these bright bands here, which is the deposition of the lead in the bone. Okay, lead lines, dense bands, more dense than the cortical bone, and they're usually in the knees, although you can sometimes see them in the wrist and other long bones, even in the axial skeleton. If you see multiple bands, that usually represents episodic exposure to toxic levels. So that may be a situation, for example, where a child's going to stay at another place for part of the year, or a situation where there's episodic exposure like that. We don't know what's a safe level of lead. There are some who believe that any level is harmful. And there was actually an interesting study that was published, I think it's been probably at least 20 or 25 years now ago, where a group went into the Andes Mountains and checked the population there, and they were actually able to measure no measurable lead at all. So there doesn't seem to be a physiologic function for lead in the body. It is a toxin that's related to the modernization of society. So the presumption is that it's possible that no lead level is safe, but the threshold for intervention is being pushed lower and lower. So the CDC currently recommends that you use a screening protocol that is related to the known level of lead exposure in the population of patients that you work with. So the population I work with in urban, underprivileged Chicago, our lead levels are going to be much higher than they might be, say, for example, in a rural Colorado. So you need to think about what kind of population you're dealing with and what the incidence of lead level is. And that's actually how they want you as a pediatrician to develop your screening protocol for your patient population. However, the threshold for screening is universal screening if you don't have any regional data available. So at a minimum, you should screen at 1 and 2 years, recognizing that by the time you get a high lead level of 2 years, it may even be too late. So the earlier you can intervene, the better. And if you know you're dealing with a high-risk population, you should start screening as early as 6 months. How do you get the blood for lead? You don't want to collect it from a capillary source if you can avoid it. And the reason is when you do a finger stick or a toe stick is that you can collect actually lead from the surface of the skin. So if your lead level comes back high, you're going to end up having to draw a venous sample anyways. Lead was an additive to paints. It was an additive to gasoline. It's not anymore. But a lot of older houses will still have paint in them. In addition, there are other risks. Foreign adoptees often have exposure to lead because the regulations might be more lax. If the child's living in a house that was built before 1978, which is about the time they started eliminating lead from paints, any sibling or play pal puts them in a higher category if they come back positive. Folk remedies, pottery, occupational, hobbies, there are a variety of different sources of lead that parents may be employing, stained glass use, that kind of stuff. Anemia is another risk that they want us to screen for, another disease state they want us to screen for. Particularly high-risk groups, prematurity, low birth weight. Any introduction of cow's milk before the age of 2 tends to lead to anemia, and then, of course, menstruating females are at risk. So how do you screen? All infants by 12 months should have a screening completed, and then again at 15, 18, or 24 months if the infant's at high risk. For childhood, if the child's at high risk between the ages of 3 and 10, and then in adolescence, we really are asked to do targeted screening. So that's instead of universal screening. Urinalysis, we're not doing this anymore, and the reason is similar to those chest x-rays I was describing with smokers. We just found that it doesn't help us in intervening early and making a difference for particular diseases. So universal screening of urine analysis is no longer recommended. Metabolic disease, this is peculiarly state-controlled, and I never have been able to understand why that is, because your risk for metabolic disease really isn't determined by which state you live in. So it should be something that should be nationalized, it seems to me, but it hasn't been. So you need to be familiar with what your state health department checks for in newborns. Something that might come up on the test, what's happening a lot now is early discharge, right? Babies are leaving the hospital much earlier than they used to. If they get the screening, the metabolic screening, too early, what does that mean? Well, it means the toxic metabolites that you're screening for haven't built up to a level yet that is going to make the screening test positive. And so what you need to know is that you may need to retest that baby. So the kind of scenario you might be faced with on an exam question would be, baby went home, but baby went home way early. Mom was doing great. Baby was doing great. You said out the door, no problem. Got the test before they went out the door, but in fact, they have a metabolic disease, and you go to look at the profile, and the profile is normal. So what's the answer to the question? The answer is repeat the profile. So if you suspect a metabolic disease, repeat the profile. Autism screening is also something we're being asked to do now between the ages of 18 and 24 months. Again, because autism spectrum disorders are not rare, and early recognition is important in intervention to promote a better outcome. So you need a strategy developed to screen all patients, to further assess those who might have a positive screen, and to know and refer to local resources. So most of us are pretty familiar with this, the three signs or the three areas which are affected in autism: the social interaction, the language, and the routine behaviors. But many of these signs show up in infancy, and one of the things that is sort of the hallmark of autism is the loss of skills that had previously been acquired. So that would be a flag for you in the question. So deficits in social skills, they don't respond to their name appropriately, poor eye contact. Sometimes they don't appear to hear, or they aren't listening, unaware of others' feelings, and a variety of other things in social situations which might stand out to you. They prefer to play alone, for example. Deficits in language, they often have this sort of sing-songy speech. That's sort of a hallmark of autism. They have a hard time carrying on a conversation. They'll often repeat words or phrases verbatim without understanding them. That's the sort of parroting that we talk about, where they just repeat the phrase but have no idea what it means. Behavior, what you'll notice is repetitive movements, sometimes rocking or spinning. They'll develop sometimes complicated rituals and get very upset if those are disturbed. They're often constantly moving. They may be actually hypersensitive to light or sound or even touch. And they may seem to not have much reaction to pain. So that seems to bother them less. So here's a question about autism for you. Regarding the association between the MMR vaccine and autism, which of the following is true? A, the design of the original study demonstrating a link between autism and the MMR vaccine was scientifically sound. B, as the number of children receiving the MMR vaccine has increased, so have the number of cases of autism. C, the MMR vaccine contains a preservative that has been linked to autism. And D, recent studies have demonstrated no association between the MMR vaccine and autism. Make a selection. Excellent. So you guys all read the study. We can move on. So actually, AAP commissioned a large study to look at the results of all the previous studies, and it wasn't too long after that one of the original investigators actually acknowledged that they had manipulated some of the data. Special considerations when you're looking at immigrant children. Many of the questions that you will face will ask you to take care of a child who's been adopted from an international source. And so it's important for you to realize that those children require treatment that may be different than a child who was born in the United States. So particularly at risk, tuberculosis, hepatitis B, gastrointestinal pathogens that they may be carrying, and then the lead level that we talked about. We're going to talk about feeding supplements and nutrition. Breastfeeding. Why do moms stop breastfeeding? Most common reason is a feeling of lack of support and an inability to deal with common problems that arise. So what does that say for you? As the pediatrician, it's most important for you to support breastfeeding, but also to be aware of the common problems that moms run into and how to deal with those. Because you're probably going to be the first line that she's going to come to after her friends and maybe her own mother, but she's going to come to you with questions and going to need support and some solutions. There are many proven benefits of breastfeeding, and I've listed for you those that are that have been scientifically proven, that babies who are breastfed have fewer problems with everything on this list. So there are a lot of good reasons to breastfeed. Let's talk a little bit about soy formula, but before doing that, let's try a question. So soy formula is indicated in which of the following infants? A premature infant. B, an infant with lactase deficiency due to gastroenteritis. C, an infant with a documented cow's milk protein allergy. D, an infant with colic. Or E, an infant from a family with a strong atopic history. So which of those is a soy formula indicated? Oh, we have a split decision here. So B and C. All right, so most of you did not pick A. That's good. So soy formula is not indicated in prematurity. So in preemies, stay away from the soy formula. D, we weren't so happy with D. So we know that even though parents will try it, you shouldn't switch formulas in a baby with colic, right? So colic's not caused by the formula, but we're going to talk about colic. E, an infant from an atopic family. So there is some evidence that, obviously reactions to certain things do in fact run in families, so that's important to realize. However, using a soy formula is probably not going to help with a cow protein allergy. So we're split between B and C. An infant with a lactase deficiency due to gastroenteritis or an infant with a documented cow's milk protein allergy. So for those of you who chose C, I got some bad news for you. And the bad news is that there's a lot of crossover. So many patients who are allergic to cow's milk proteins are also allergic to soy protein. And so the recommendations for an allergy to a cow's milk are to move directly to a hydrolyzed formula. So by hydrolyzing the formula, it removes the allergenic property of that formula, of that protein. Okay, so using a soy formula in the case of B actually is acceptable. And one of the choices I didn't put on there, which is probably the most common reason I see now why patients use soy formula, is because the patient's family have elected to be a vegetarian, and they're trying to be more vegan and avoid animal products of any kind. But B actually is a way to use soy formula, because what happens in gastroenteritis, you have to remember that lactase is on the brush border. And so when you've got gastroenteritis, you're washing away that brush border. And so the body needs some time to actually repopulate the lactase. So putting a patient on a soy formula in that setting is one of the ways to treat the patient. So term infants only, soy formula is nutritionally complete. There are some indications that you will see vegans who don't want to use any animal products, galactosemia, or a lactase deficiency. The problem with cow's milk allergy is that 15% of those with a cow protein allergy will also have a soy protein allergy. So that's a big enough percentage that you probably don't want to be introducing another allergen that they're going to react to. So you go right to that hydrolyzed formula. After the patient's been rehydrated in gastroenteritis, a soy formula can actually be pretty effective. But don't switch any of these patients to soy. No preemies. Don't use it as a prevention or management of colic. Don't use it for patients who the parents report are just fussy. And it's not a way to prevent atopic disease. So we should be recommending the delay of whole cow's milk until the age of 12 months, using formula or breast milk for the first year. Babies need more fat, and so whole milk is recommended once you do introduce milk. So that fat content is 30 to 50% of the calories that are consumed. After age 2, then, we recommend the use of reduced fat milk. You will be seeing some babies in your clinics that the residents often refer to as milk babies. These are the babies for whom there's been early introduction and large quantities of usually cow's milk, and that can result in some occult GI blood loss and some iron deficiency, as that all that calcium bombards the body, and actually you have to remember that divalent cations in the body have the same carrier in the GI tract. So anything that's a divalent cation like lead or calcium or iron are going to share the same carrier and compete with one another for absorption. Feeding issues for toddler, what's the biggest problem? The establishment of a routine. And so a lot of counseling with parents around allowing toddlers to feed themselves, allowing them to develop a set routine where there's a meal time or there's a snack time, but not allowing sort of grazing throughout the day, turning off screens, using meal time as family time is really an important part of the development of the toddler. We're going to talk a little bit about supplements, so let's start with vitamin D. All of the following are true about the most recent recommendations for vitamin D, except, so one of these is not true. A, all infants should receive vitamin D supplementation. B, daily recommended dose is 200 IUs per day. C, breastfed babies are at risk for vitamin D deficiency. D, supplementation should begin soon after birth. And E, supplementation should continue through adolescence. Which of those is not one of the correct answers? Okay, so most of you recognize that the dose in choice B was not right. It's actually 400 IUs per day. What's being recognized is that there's a relatively limited supply of vitamin D sources, and that it's impossible to know who's getting adequate sunshine to convert the vitamin D to the active form. Sun exposure is not recommended, right? We're all trying to reduce the incidence of skin cancer, so we're trying to stay away from excess sun exposure. And so the recommendations call for supplementation for everybody through adolescence. Iron deficiency, probably the most common micronutrient deficiency that you're going to see. It is the most common micronutrient deficiency in the world, but it's even a problem in developed countries. So in the United States, when you see a child who's anemic, your first 3 items on your differential diagnosis are iron deficiency, and iron deficiency. Okay, so in fact, it probably makes sense for you to go ahead and treat the iron deficiency for you in dealing with a patient who's anemic, who's at risk for iron deficiency, and then checking the hematocrit again. But the highest risk groups are menstruating females and in between the ages of 6 and 24 months. So iron supplementation is recommended for everyone. Generally speaking, the formulas are you're all set with formulas, so you don't need to worry about that. The fortified formulas work pretty well. There's iron-fortified cereals, plus there are supplements available. It's not as necessary in the term breastfed infants because even though iron is less abundant, it seems for some reason in the breast milk to be more bioavailable. So the baby seems to be able to absorb a much greater proportion of the available iron. All right, we're going to talk a little bit about discipline. And I need to preface this section of our discussion with something. And this introduces a number of topics that we're going to talk about that have political ramifications or about which all of us tend to have pretty strong feelings. So what you have to do for the test is you have to set aside your personal beliefs. You have to set aside your opinions about some of this stuff. And you have to think about, okay, what what are the recommendations from the groups, from the American Academy of Pediatrics and others. Acceptable forms of discipline include gentle verbal reminders, the all-time favorite timeout, which depending upon the age of the child can be very, very effective. The loss of privileges, which is generally used for older children that have then the understanding of consequences of their behavior and can actually see, are old enough to be able to see into the future and recognize, well, if I do this now, then there might be a consequence that I'll be upset about later. That requires some development and only occurs later. Modeling is always a positive influence, and so probably the best way to talk to parents about modifying undesirable behavior is having the parents model the behavior that you do desire. But the bottom line is underlined and in italics is never, never, ever use corporal punishment. So it's just simply not acceptable. And so, just to highlight the example, we had a lunch meeting in our office, and just out of curiosity, I asked how many people in the room had been spanked as a kid. And about 3/4 of the people, these are all nurses and doctors, raised their hands. And then I asked, well, how many of you think it was an effective form of discipline? And about the same 3/4 raised their hand. So, what your personal opinions are up to you, and many of you are parents, not just pediatricians. So I know that you have your own techniques that I'm sure work. But I can tell you that from the perspective of the American Academy of Pediatrics, corporal punishment is not acceptable for a variety of different reasons. The first and foremost of which is it's hard to tell a kid not to hit somebody when you're hitting them. So they don't necessarily have the ability to understand that. The timeout is the all-time favorite. Can start as early as 9 months. So what's the timeout all about? It's about just removing the patient from the thing that's causing the problem. And it's depriving them of any contact. So you have to tell the parents, well, part of the timeout is that they're deprived of the benefit of your interaction with them. So the timeout's not effective if the mom or the dad is kneeling next to the child and sort of coaching them through the timeout. Okay, so the point of the timeout is to get some deprivation of contact. And you can tell parents that they can even, if the child won't sit in the place for timeout, they can actually have them. You can impose a timeout by just physically restraining the child in your lap and having no contact with them, other than the body contact to physically restrain them. So it doesn't take much time. We sort of talk about a minute per age to a maximum of 5 minutes. No discussion during the timeout, and you can have a little debriefing afterwards. After about the age of 5, as I mentioned, we talk about loss of privileges. They're now able to understand this, and it can be a more effective way to discipline this group because they actually understand the consequences of their action, and they understand that if they do something now, it may have adverse consequences later. So that's when you talk about taking away screen time or taking away a favorite activity or something like that as a punishment as opposed to a timeout. So one of the things that's become a real problem in the complexity of the modern world is families have taken on many different types, and so a family has a very broad definition now, and what the family situation is for your patient may be very different than what we used to traditionally define as the two-parent family, and so that makes discipline a bigger challenge. The reason is you often have more people involved. You may have aunts or uncles. You may have step-parents. You may have step-brothers and sisters. You may have a patient who's got split custody where they're spending half their time in one place and half their time with the other parent in another place. So this is when it's important to keep it simple, be consistent between family members and settings and similar episodes of this behavior. And the most important thing is for there to be a temporal relationship when you're talking about younger kids between the misbehavior and the consequence, which is the timeout. All right, let's talk about speech and language development. Another question for you, and this is a classic board question, as much as you may hate it. I promise you, Scout's honor, that you will have a whole host of these questions. And as Tommy pointed out in the beginning, as painful as they may be, what you have to do is just try to memorize some of the major milestones. And how do you do that? What's the easiest way to do it? If you have children, think about your own kids. For those of you who don't have children, or for like me, my children are old enough that I can't remember when they did what, that you need to go back to nieces and nephews or neighbors and think about how you can set some of these milestones into your brain. So this is a classic question. A child understands almost 100 words, speaks a few simple words, follows one-step commands, and is rapidly acquiring the names of objects. How old is this child? 2 months, 5 months, 10 months, 15 months, or 20 months? Okay, so that's a good estimate. The best estimate for this child is probably at 15 months. Now, sometimes you might get some things in the question, like they'll tell you what the child can't do, and that can be helpful as well. But one of the things we're going to talk about is some of the language milestones, and these are important to be pretty familiar with because it's very, very likely that that handful of questions, that many of them are going to relate to verbal milestones. So always think about what the parents are concerned about and always focus on early intervention. So here's some normal development for you, 0 to 10 months. We call the pre-speech period. 0 to 6 months, they're able to localize sounds. They coo, which is they may be doing it randomly and initially. Eventually, they actually can do it interactively, so you can have a conversation back and forth with cooing. They may learn some simple names like mama or dada, and then they start using consonants and adding vowels and babbling. 10 to 18 months, this is the rapid naming period, and this is where you can encourage parents who are focused on verbal development of their children, sort of narrate your daily life, right? So you say, I'm going to the refrigerator, I'm going to get you a glass of milk, we're going to pour it into a glass. I'm going to give you that glass, and we're going to set it on the table. So it sounds kind of silly, but actually the kids love it because you're talking to them and naming all these things that they're starting to really absorb like a sponge. 18 months, you start getting word combinations. Usually occurs when the vocabulary is over about 50 words. You might have simple constructions of first sentences. And the last bullet on this slide, parents just go crazy about this, right? They come to you, they're all worried that their kid's got a speech problem because they're not using prepositions or they're using pronouns wrong. They're saying me instead of you or I instead of me. You need to just tell them to just chill out, right? It's not anything they need to worry about, okay? So it's totally normal. It's a developmental phase. All right, another question. You diagnose speech delay in a patient with a normal physical exam. Which of the following do you do first? Okay, emphasis on the word first. So a lot of questions are constructed this way as well. So A, consult an otolaryngologist. B, advise the parents to learn sign language. C, enroll the patient in an early intervention program. D, order a hearing test. Or E, diagnose autism. Good. So you were listening the last time we talked about this. Here's your knee jerk, right? Notice in the schematic there's no brain, right? No brain involved. It goes right through the spinal cord, okay? So that's what needs to happen here. All right, so possible causes of language delay. Number 1, hearing deficit, mental retardation, structural problems, elective mutism. Child decides not to talk. It actually happens. One of the worries that you have then in that situation is social deprivation. Child abuse or neglect, dysphagia or dysarthria. I gave you the definition of those two, although I don't think it's that big a deal. You need to just remember there is a difference between the ability to form language or use language or understand language and the ability to actually articulate language. Red flags for a language problem: 9 to 12 months, absence of babbling; 18 months, absence of any words; 24 months, absence of meaningful phrases; 3 years, speech that's not intelligible by strangers. So this is the kind of slide that you'd try to memorize right before the exam. Okay, here's a set of milestones. These are red flags. All right, we're going to go through some common problems. You probably have been watching the news or paying attention to what comes out in the news. You know, my best source of medical information is NPR. So generally what happens is NPR comes out with a story and then I'll read about it. But one of the things that got big not too long ago was the use of cold medicines, and especially really small children, children under the age of 2. And what was realized is that there were more ER visits as a result of cold medications used in these patients than there was any curing of any cold, right? So cold medicines, by the way, are pretty useless anyways. So because they're pretty useless anyways, we shouldn't generally be using them at all. But we certainly shouldn't be using them in children under 2. And so now we're advised to tell parents, you know, you can use a variety of different measures. Whether you want to use steam or, you know, lemon fragrance or whatever, or some sort of application of a rub on the chest, you know, those kinds of things are probably all pretty safe. But no cold medication, because what we find is that it hurts the kids more than it helps them. All right, we need to talk about otitis media. So this is a schematic of the anatomy of the ear, just a reminder of the 3 major portions of the ear: the outer ear, the middle ear, and the inner ear. Our focus is going to be on this, the middle ear. There are, as you know, a lot of disorders of the external ear, probably the most common being otitis externa or swimmer's ear, the tympanic membrane here, but the area of our focus for the next few minutes is going to be in this area, in particular this area right here. And why are we worried about that? Well, because, as you know, otitis media is a big problem, and our thinking about this is evolving a bit. So you need to think about maybe what you learned when you first started residency and what's being practiced now may be a little different. That certainly is way true for me. But we talk about the difference between acute otitis media and otitis media with effusion. So acute otitis media, and here's the kicker, it needs to involve the acute onset of symptoms. So you can't make the diagnosis of acute otitis media without the acute onset of symptoms. You also can't make it without the presence of a middle ear effusion. So the effusion has to be there, and you have to document it, and the best way to do it is with pneumatic otoscopy. Okay, so instead of when you got students and residents in your office, having them look in the ear, yeah, looking's good, but you need to tell them to go and buy one of those cheap little black bulbs that you attach to the otoscope and you puff a little bit of air in there, because they need to be able to learn how to see if the tympanic membrane's moving or not. That's the key. Then there needs to be signs and symptoms of middle ear inflammation. So if you have all those 3 things, then you can think about diagnosing acute otitis media. But what we think is that we're way overdiagnosing this. So what most of us are facing most often is otitis media with effusion. That's not acute otitis media. What is it missing? It's got the middle ear effusion, right? There's the effusion, but there are no signs of acute otitis media. So they don't have the acute symptoms. And there's no sign of middle ear inflammation. Okay, so very common situation. 90% have otitis media with effusion before school age. So almost every single one of your patients will have it by the time they get to school age at some point. Most common between the ages of 6 months and 4 years. Most will resolve spontaneously within 3 months. And otitis media with effusion decreases the mobility of the TM, so it becomes a barrier to sound conduction. So why is it important to you? Not because you need to prescribe antibiotics. No antibiotics. But it can affect speech development. So when do you test the hearing? If it persists for longer than 3 months, if you have documented language delay, if there are learning problems, or you're worried about a hearing loss. Otherwise, watchful waiting for 3 months. No medications. No antihistamines, no decongestants, no cold medicines, no corticosteroids, no antibiotics. So no medications. For acute otitis media, we're being asked to take a new approach as well, and that approach is a more judicious use of antibacterial agents. So not everyone with an acute otitis media needs antibiotics. So, and the reason is because it's the #1 use of antibiotics, way overused for children, and it seems to be contributing to the development of resistance. It's a cost. There are side effects to using antibiotics, even things as simple as amoxicillin. Kids get diarrhea, and there are adverse consequences of that. So it's not something that comes without cost. So a new approach to consider an uncomplicated acute otitis media is no antibiotics at diagnosis, with the rising rates of resistance and the cost. The complications of acute otitis media are extremely rare. So watchful waiting for several days with analgesics is acceptable. When should you consider antibiotics? If you have a patient who has anatomic abnormalities, especially such as cleft lip or palate, cleft palate in particular, any other facial abnormalities, genetic syndromes such as Down syndrome tend to come with higher incidence of problems or complications of acute otitis media. Any immunodeficiency, a cochlear implant. If it's a recurrent acute otitis media within the last 30 days, think about antibiotics. And if you know you have underlying chronic effusion, then you might want to think about antibiotics. Tympanograms is another thing that many are using in the office now. Some of you may have handheld tympanograms that you use in diagnosis. So you need to be familiar with these because there's a possibility you'll be presented with one on the exam. You want to look at the point of maximal compliance. That's the peak on the y-axis, normally about 1 cubic centimeter. The peak pressure, that's the point of greatest mobility, where the peak seems to line up on the x-axis, and you want to look at the width of the curve. So here's a normal curve for you. So what you can see is the normal curve centers on the 0 mark, and you can see it's got a fairly narrow distribution. And although it's not marked over here, you want to look at the volume of air that's going in as well. So this is showing you that there's no middle ear pathology. You have an intact and mobile tympanic membrane. You have a normal eustachian tube. And if there is a hearing problem, that it's probably not the middle ear. So here's another tympanogram. So let's approach this one. This is the tympanogram of a 3-year-old boy with no symptoms. What's your diagnosis based on the tympanogram? Is it A, a normal tympanogram, B, evidence of acute otitis media, C, evidence of a perforated tympanic membrane, or D, evidence of eustachian tube dysfunction? Which of those is the best choice as an interpretation for this tympanogram? Okay, so D is the correct answer. That's great. It's not a normal tympanogram. It was off the 0 center. It's not acute otitis media. Why? Because the patient didn't have any acute symptoms. The patient was not in distress. So and I didn't tell you what the TM looked like, but you'd want to know. This TM likely had no appearance of any inflammation. A perforated tympanic membrane actually leads to a large volume of air, and that was a normal volume, so the TM wasn't perforated. So most likely explanation was a eustachian tube dysfunction with the shift to the negative side for the peak of the tympanogram. All right, this shows you what the normal levels are for hearing for sounds that we're regularly exposed to. One of the things that's of interest is there is evidence that losing the ability to interpret sounds that are as soft as 50 decibels or even lower can actually affect the acquisition of language. So there's some significance to deafness, and we've talked a little bit about the importance of hearing screening. But there are significant consequences when it occurs, and it's related to the acquisition of language. So even as I mentioned, not being able to hear some very low levels of sound creates a problem in language acquisition, even as low as 15 decibels. I already mentioned that otitis media with effusion is one of the most common causes of a hearing deficit. So you need to be vigilant about monitoring those kids who do have OME to make sure it's not creating a problem for their language acquisition. This just shows you a representation of autosomal recessive inheritance, which is 80% of the acquisition of genetic hearing deficits. And those deficits for deafness are half of those cases. So again, very significant. Among those that are not genetic, infectious etiologies, majority like CMV and toxo, rubella, bacterial meningitis. But the bottom line is hearing screening for everyone with early detection and early intervention. So everyone gets screened, and if they fail the screen, they get a complete audiological evaluation before the age of 3 months. So that's how important the AAP now believes hearing deficits to be. All right, we'll talk a little bit about vision problems. So here you're doing a screening test for the red reflex, a nice representation of the red reflex here, and a problem as well. So if you discover this abnormality during vision screening, what should you suspect? A, retinoblastoma, B, glaucoma, C, neurofibromatosis, or D, Sturge-Weber syndrome. Go ahead and grab your button box. All right, excellent. So retinoblastoma. The other that wasn't on the list is a congenital cataract that can sometimes obscure the red reflex. You're just not getting enough light through, but that is a good screen for retinoblastoma. Strabismus, we talked about the misalignment of the visual axes. It can be continuous. It can also be intermittent. That's sometimes caused by being tired. The result may be amblyopia, which is that syndrome that I mentioned to you before, where the brain actually stops paying attention to the signals coming from that eye that's so out of access that the brain can't integrate those images. So it's one of the most common causes of loss of vision in pediatrics. It may be due to a refractive error. So if one eye has a significant refractive error, the strabismus we talked about, a congenital cataract or other, or causes of a corneal opacity. So you don't want to lose vision in that eye. So it can't be corrected with a lens, but the prognosis is good if the patient is young enough at the time that the problem is detected, and the cause and severity of the amblyopia can be corrected. For that simple malalignment of the visual axis, an occlusive patch is often all you need. So that'll take care of the problem. So what do you patch? You patch the bad eye or the good eye? You patch the good eye. Okay, so what do you do in patching the good eye is you force the child to use the bad eye. So the eye that's out of alignment, or the non-dominant eye, now is the only eye the child has to use. Therefore, you're not going to lose the signals. A little bit about head circumference, just a reminder of the various types of bones that are a part of the normal skull of the newborn. And remember, we talked at the beginning about definitions of normal. And so for macro and micro, it's going to be the same. So you're going to have a normal that's defined by a distribution. And so by definition, about 2.5% of the population is going to be in either ends of that bell-shaped curve, and are going to be defined as micro and macro. One thing to notice about this cartoon is that you see the shape of the head versus the shape of the microcephaly. Another thing I'll point out to you is that the most common cause of microcephaly is not the fact that the bones aren't growing, it's that the brain's not growing. And so what spurs the bones to grow is the underlying brain growth. So one of the things that should lead you to remember is that if you have a problem with microcephaly, the first thing to worry about is abnormal brain growth. Because if that brain is not growing right, then that skull's not going to grow right. So a little bit about plotting preemies. We talked about this already and correcting for catch-up and allowing them time to catch up. The hydrocephalus is particularly common in preemies, right, because they have the risk of intracranial bleeds as a result of being premature, and so that can lead to hydrocephalus. So sometimes it's hard to sort out what's macrocephaly and what's hydrocephalus. You need to be aware of that. What do you do if you suspect abnormal head growth? Always the default answer is a complete history and physical. Take a look at those growth curves and see what the pattern shows, and then think about any associated findings. So developmental delay, focal neurologic findings, any neurocutaneous disorders. Those are all things that should cause you to worry. Again, as I mentioned, the brain growth underneath is what causes the skull to grow, so that's what you're going to be paying attention to. And for primary microcephaly, it's usually a genetic or chromosomal disorder in which brain growth is abnormal, and that leads to the microcephaly. For secondary microcephaly, that means the brain growth was normal, the head growth was normal initially, and then it gets arrested by something that's most commonly a toxin, infection, or an injury. So that's how you can separate out those two. Again, how do you figure that out? You look at the curves. Look at how the head has plotted in its growth. Macrocephaly, too big a head. I mentioned hydrocephalus is one possible cause, excess brain tissue or thickening of the skull, and then, of course, a bleed. Any of those obviously incredibly concerning. So macrocephaly is something that you don't wait on. This is a schematic to remind you of the various organs that are involved in the development and the flow and the processing of cerebral spinal fluid. As you know, it's an incredibly complicated system that can go wrong in a variety of different places. One of the most common complaints that parents have these days is what's called plagiocephaly. Plagiocephaly is an asymmetric head. And the cause of that, the most common cause right now, is our good efforts at the Back to Sleep program. So you can see this kid's experience plagiocephaly, which is a flat head, as a result of always sleeping on his back. So what's the problem? I mean, the good news is we've dramatically reduced the incidence of SIDS by putting everybody on their back to sleep. There's some really good evidence of that now. The bad news is we've got this new set of kids who have plagiocephaly, but it's positional, and you can tell parents it universally goes away. It resolves as the kid spends less time on his back. And if parents want to do something, you can tell them, well, when the baby's awake, that they can be placed on their tummy more often.